Yeah, I'm Ian Rennick. My day job is that I'm the Chief Executive of the Queen Elizabeth Hospital in Gateshead, and one of the pleasures as a kind of spin-off from that is chairing this collaboration. It's great to see that so many have made it here. I'm slightly reassured that it wasn't only me who had to battle through the traffic, so well done to all of you who stuck with it and have made it here this morning. Welcome to St James's Park. As you can possibly tell, this is part of my spiritual heritage, and speaking as a season ticket holder of 33 years, you should be thankful that those windows don't face the pitch, particularly this year. This is the programme for today, and apologies again for the slightly late start, and thank you very much for everyone who's been very patient in allowing colleagues to catch up. I'm assured by Catherine, who has got today's event organised down to the minute. We've got plenty of wriggle time to allow us to catch up and get you out of here bang on 3 o'clock. Then you can have another hour and a half getting across the bridge to wherever you consider to be home. So there's your programme for today. I'm particularly delighted to welcome a number of honoured guests here. Professor Carl May, who's the Professor of Healthcare Innovation at the University of Southampton, who's come to share his insights and expertise with you, and Dr. Tracy Finch, Tim Rapley and Melissa Girling from Newcastle University, who are going to take the lead on today's masterclass. And you'll see we've got tables dotted around along the side of the room here that'll allow you to go off into your break-off groups. A bit of housekeeping. There's no fire alarm planned today, so if the fire alarm does go off, follow me. If you hear alarm, it's going to be the real thing. You've got to proceed back out to the car park, which is back the way you came in, along there, downstairs to the Milburn reception, and then the event staff, our team here, will take a roll call. So just let them know if you've left early, please, and that'll be helpful just in case that should happen. Toilets, if you haven't seen them already, are just back out of the door where we came in on I think both the gents and the ladies are on the right-hand side. If you require Wi-Fi access, there's the code, there's the Twitter feed. I'm still not onto Twitter yet, and I'll get myself into that one day, but you'll know what you're doing with those hashtags and @ down there. And finally, it is really important today. We've got some very special guests here to talk to you who've come a long way. Please turn your mobiles onto silent or onto vibrate, and try only to field calls during the breaks if you can, just out of respect for our speakers. And as you've probably noticed, the masterclass is being filmed throughout the day, so don't worry too much about our colleagues here. So just a little bit about the partnership if you don't know about it. It's a key component of the North Eastern Cumbria's Allied Health Sciences Knowledge and Information Work programme, and that's delivered by NEQOS, the North East Quality Observatory. Our aim is to support you, enable you to provide patient care, and one of the things that we're particularly thinking about at the minute is the way we roll out best practice through things like NICE guidance in a consistent way and as effective and efficient way as we can right across the northeast of England and Cumbria. And today is going to focus on the application of Normalisation Process Theory, which I know nothing at all about, but we'll call it NPT for short for the time being, as a tool to help with that. Sorry, I'm just guiding my way through the technology. Yeah, and we've got some experts on that here to talk to you today, and that's not me, I have to say, as you can probably tell. Some of you have completed an online survey in advance of today, and I know that Tracy and her colleagues have had a look at that, and they've used that as an opportunity to try and tailor the event to what you've already fed into the process. So it's a little bit of Tesco's isn't a very good example to pick today in particular, is it, with a 92% drop in profits, but we've done a little bit of you said, we did around all of that. And as you probably know, our key priorities are COPD, frailty and end-of-life care. And again, you'll see that we've got some whiteboards up that show you where the relevant places to go are for the breakout groups and the workshops later on. Yeah, so we're going to use those three key themes, say grouped into disease groups and condition groups, to use NP to explore on that. essentially is going to be applied, it can be applied to any health condition, but what we've done is we've tried to condense things down into a small manageable number of what we consider and believe to be the key priorities from across the North East and Cumbria in terms of setting off the work of the collaborative. So on that note, I'm going to get away from the technology because it clearly doesn't like me this morning. I'm going to hand you over to Doctors Tracy, Finch and Tim Rapley from the Institute of Health and Society at Newcastle University.
Okay, thank you. Right. So, yeah, clearly this masterclass is about normalisation process theory, and we just want to give you an introduction to what it's all about, how you might use it, and to give you a feel for how it could be useful in your own work, we hope. I want to say that we've arranged today so that it can be very interactive. We do have some content in between the workshops, but hopefully you'll find that it's more about doing and talking rather than just listening to us. So hopefully that's how you'll find the setup for today. And really, I've put on there to play with the theory, because really we think this is important with NPT, and hopefully you'll go home with that message that it's not something that's rigid, it's not something that you have to follow lots of rules, it's a guide to thinking. And this gives you an idea of the mix of people that filled in our survey. So quite a lot of healthcare professionals and people in more managerial roles, but a mix with some researchers as well thrown in there. And I think one person that classified themselves as a clinical academic. And clearly these categories are what you make of them yourself, but it's just to give you a feel. So we asked people, were you already familiar with normalisation process theory? And so you can see from the slide there that there's quite a good number, nearly half, nearly half who have heard of it but don't know much about it. And so I guess that's a good place to be in terms of coming into this workshop. Some people have heard us talking about it in other spaces, and that's great. We would hope that by the end of the day, people would be able to say that they know about it and they can use it. And we also asked what people wanted to take away from this day, and overwhelmingly, the most common response was to get some more practical knowledge to apply it in their own roles, in their own research projects. So a real emphasis there on the practical. So you'll see today that we're trying to that's how we're trying to get our messages across in a way that you can take it away and apply it. So there are just a few things there that came out of those responses. And some people want to go away and apply it to very specific things that they're working on, and that would be great. That's what we would hope you could do. Some to just improve their general knowledge around the implementation process. And as you'll already be aware, this is just one approach amongst a lot of different approaches within implementation science for understanding how new practices and interventions become embedded. So we asked people to work through a series of questions, either using their own example or using one that we'd pre-made. And there was a bit of a split in terms of what people did, quite evenly. We didn't have enough time to do any kind of in-depth analysis of the responses to all those detailed questions. However, we will do that and feed that back, because I think some of you may be interested in seeing what comes out of those results. But this just gives you an idea of the kinds of things that people are working with, that they're wanting to think about the implementation of. So a good range there. And what you'll see is that these are things that are quite complex, and we'll come on to complexity at a number of points in the day. So I don't want to say a whole lot about this. We don't really have time to go into it, and I think some of you may have been in other masterclasses and have heard similar things already. But getting interventions, even if they're proven to be effective, getting them into practice is still problematic, and it involves a lot of work. And so we have this growing area of research around implementation science to really try to tackle this and understand it and to provide tools. So we're just one part of that. there is a call for these interventions and approaches to be more theory-based, and there's a lot more emphasis on theory. But theories, there are so many different theories. How do you know which one to use? How do you know which one's going to be useful? And sometimes you have to try to translate the quite difficult concepts that we present within these theories so that you can actually use it. And so what we're trying to do today is help you to translate the ideas within the theories into a much more practical tool. Okay, so they come from different perspectives, and so you'll hear a lot more in the presentations that follow about the NPT perspective. Because of time, I won't say anything really about this other than to just note that this is how we describe complex interventions, and anybody trying to do complex interventions within their work, within their research, will recognise these features as things that do make implementing new practices really very difficult. And that's taken from the MRC framework for complex interventions. So normalisation process theory, I really don't want to say too much about at this stage because we're very fortunate to have Professor Carl May come and tell it in more detail from his perspective. But really it's just a theory about how new technologies and practices become normalised, how they become embedded. And that's different to people just using them and deciding to take them up. What we're interested in is the sort of longer term process of how they become just part of what people do, so that they no longer have to think too much about what they need to do it, so that they become second nature and they become easy. And from an NPT perspective, what we really focus on is not individuals and what individuals do, but how people work together, because implementing pretty much anything involves lots of different groups of people, and it requires people to cooperate and all contribute their bit. So we don't focus on one individual perspective at all. It's really how people work together. So we're interested in attitudes and practices and the things that individuals do, but we're really interested in the context and the intervention itself and how all of these three things come together. So if those of you who really want to get to grips with the detail of the theory can go and have a look at some of these papers. I'll just skip over those. And this is our kind of summary sheet, if you like, and you'll see this around during the day, and it's in your packs, and it's kind of just a prompt to remind you what it's all about at a very general level. Because we're pushed for time, I won't say anything in detail about these four constructs now, but you'll become familiar with them as we go through the tool and the workshop and Carl's presentation as well. Okay, so the practical question is, what is NPT actually useful for? And what we'd like to say and start off by saying, hopefully end by saying, is that we think it's a tool for thinking and a tool for planning, and so it's to help you think through issues of implementation, and there is a structure behind it. There's a lot of observational work behind it that we've done, and so it's kind of grounded in an understanding of what happens when people do actually try to implement these very complex practices. Just to flag up, there's a growing body of published literature that uses NPT, and if you want a good overview, this review paper by McAvoy et al. Is a good place to start, and their review is of 29 studies. And that's just to give you an idea of the kinds of areas that have been researched using normalisation process theory. Most of them have involved qualitative research, so that means asking open-ended questions. But increasingly, some studies are taking a more structured approach and using survey work as well. And some of them are reviews that have used use the theory. And I'll be talking in a bit more detail about that after lunch. This has grown out of lots of different projects involving lots of different people who have worked on them. So I'm just highlighting there just some of them, and I haven't put individuals' names because there really are so many. But these studies have been quite significant in contributing to the development of the theory, as well as the kinds of research questions that we were asking in those particular projects. And I did just want to flag up and acknowledge some thanks to Elizabeth Murray and Rosa Lau, who ran a workshop on the 9th of October and did lots of great stuff with normalisation process theory, a little similar to what we're doing today. And they shared some of their materials with us, so I wanted to just say thank you for that.
So look, I'm Carl May. And I'm a social scientist. I've worked in clinical settings for my whole career. I've never worked in a mainstream social science department for all kinds of reasons, good and bad. But one thing that I've noticed in my own discipline is it has a sort of similarity with organised crime. And the similarity is this: where organised crime might make you an offer you can't refuse, sociology makes you an offer you can't understand. And so my deal here is to make you an offer that you can understand, and that's what NPT is about. It grew out of our observations of people struggling to make things happen and trying to understand why things weren't happening, and forever being confronted with lists of barriers and facilitators, as though somehow if we take all the facilitators and amplify them and take all the barriers and subtract them, somehow it will work. And it never did. And that's because barriers and facilitators aren't the opposites of each other. They're very different things. And so I, with others, and Tracy and Tim, who were members of my colleagues of mine in Newcastle at the time, we began to sort of think about why complex intervention RCTs so often failed. And they failed to recruit, they failed to work, their interventions themselves were in some way deficient. And we began to ask ourselves whether there was not a problem with the way in which people were thinking about human behaviour, or what lately has become called human factors in the NHS, that needed to be solved in some way. And look, a theory isn't a religious commitment. It's a way of thinking through a problem and explaining it. Theories are very practical things. And as Tracy and Tim have been saying, this one's all about the work. It's about who does the work, what the work is, how the work gets done, and how we understand the effects of that work. These are aspects of human behaviour that are important and crucial, and it's vitally important to note that they are things that are observable. An important problem in understanding implementation problems, not just in the NHS, but in any context, is that we often talk about it in terms of people's attitudes to something or how they feel about it. And very often we either overestimate or underestimate the importance of those factors. But there's a real issue here, is that sometimes how people feel about things is irrelevant. It's just irrelevant. So the very first people to ever use NPT, practically, weren't people in the NHS. It was the Royal Navy. And they used it to analyse launch procedures for Tomahawk cruise missiles. Now, that's a thing that I didn't want or intend work that... I didn't see myself as an instrument of mass destruction. I saw myself as an instrument, as generations of students will tell you, as a failed instrument of mass instruction. But the key point is that those guys who are operating around these very complicated and hugely dangerous systems, because let's be absolutely clear, manhandling nuclear weapons is a dangerous business, and it's one to be avoided, I'd like to say. But these are people who don't have much choice about what they do. They're working in a very disciplined, controlled environment. Their attitudes are irrelevant. Their personal feelings about what they're doing are irrelevant. And there are lots of moments like that in healthcare. There are lots of moments where how people feel about a person or a thing is irrelevant. There are things they have to do. And they have to do those things because sometimes people will die if they don't. And you know, we often talk about, for example, implementing systems to manage chronic disease in the community, as though all of those people, all that they do is manage their symptoms. But actually, they're extremely ill sometimes. And we're talking about COPD. People may not manage their symptoms well because they're suffocating. You know, there are important things about what are happening to people that we need to constantly keep in the back of our minds as we think about implementing clinical interventions or organisational interventions. They can have really, well, they are morally significant things. They're not just technical operations. So we were interested in how things crossed translational gaps. And you know, here's a model of some translational gaps. It's by a great American guy who, dissatisfied with the fact that there were two translational gaps, felt that there should be more, and so invented T3 and T4. And I live in the world of T4. I live in the world of the real world of health outcomes and health behaviours and healthcare practice. I don't live in the world of discovery and biomarkers and life sciences. I don't live in the world of patentable things. I live in the world of people struggling to do things that are important to them. And herein lies the second problem that we encountered as we were developing NPT, which was the problem of the randomised controlled trial. And these were fabulous. They were beautiful. They were elegant statistical constructions with fabulous protocols. And they would produce a whole range of confidence intervals and p-values, and everybody would be very excited because something was statistically significant. And the paper would come out in the Lancet or the BMJ, and everybody would say, God, we've got to do that here. And then they'd think, oh, how? There was no kind of information about how to do it or what might make it work or fail. And there was no understanding of the mechanisms that might propel an intervention into practice. So we got quite excited about thinking about implementation not as a dry problem of evidence, but as a practical problem of moving things from one place to another. Now here's the bridge of implementation and translational research. And obviously the valley of death is failed translation. You know, when I was in my teens, I and my family were members of a very evangelical Baptist sect, and I used to get shown a bridge like this, except the pillars were sin, girls, drink, drugs, cigarettes, and it wasn't the bridge of risks, it was the bridge of faith. And the valley of death really was, trust me, it wasn't a place you wanted to go. Although exploring the pillars was a very exciting and interesting, exploring some of the pillars was a very exciting and interesting process. So, that we see this, we often see translation of evidence into practice or ideas through implementation. We often see this as a one-way street. There is an immutable sociological law that sociologists who are interested in technology consistently screw it up. They either pour water into it or they switch it off or... Okay, let's see if I can go back to where I was, the valley of death. But look, okay, yes, I've done it. I was so proud of myself. It starts here and it ends there. Well, actually, nothing in real life happens like that. Nothing in real life happens like this. It starts somewhere here, it carries on there, it falls down there, it works back, and everything that we're looking at is a recursive process. Everything that we look at in implementation is a recursive process. It starts somewhere. It's mediated by other important factors. It's moderated by context. And in the middle, there are reinforcement effects or things that damage it, that drive back to what looks as though it was the starting point. And so the sort of paradox of implementation is that the starting point is often in the middle of the process. You know, I'm not going to get too zen about this, but there's a thing there that's really important, which is the starting point is often not the chief executive's office, or the office of whoever's deciding that we're going to adopt some system of practice. It's often somewhere else. So, moving on from my own kind of slightly unfortunate teenage years, we want to think very briefly about what implementation is. We're talking about implementation science. We're talking about implementation theory. Well, when we think about implementation, we're not thinking about, we're not thinking about adoption. We're not thinking about diffusion. Those are separate and different things. We're thinking about people making a conscious decision to do something. We're thinking about people enacting something, joining in, making it coherent, and monitoring its effects. Okay? This is the core of implementation. Implementation is doing and action. It's not changing attitudes. It's not changing beliefs. It's not people discovering something in the ether. So here's just a very quick example of what I mean. As a lecturer and as somebody who gives talks, for the first 10 years of my professional life, I would scrawl them on sheets of acetate. I would then throw them on an overhead projector at a bad angle or upside down, and an audience would struggle to read my handwriting. Or it would catch fire, as it did on one beautiful occasion in the University of Liverpool. The whole edifice just burst into flames. It was fabulous to behold. But one day I noticed that I didn't do that anymore. I just suddenly noticed that I was standing in front of 3 bullet points on a screen. And that had happened without me noticing something, because it had just got normalised. It had become routinely embedded in practice. And not just that, it had completely reshaped the way that I talk to people. So now I talk to people in blocks of 3 bullet points. And often, or until recently, I would show them cartoons from the New Yorker as I did so. Then I got a cease and desist letter from Condé Nast, who published the New Yorker, indicating that if I carried on doing that and then putting my slides on the web, I was going to spend 5 years in the federal pen sharing a room with a man called Raoul, who was going to introduce me to the joys of the Aryan nation. And I felt that I'd denormalised that bit of my practice. So suddenly this got embedded routinely in practice. And if I had actually if I'd really turned it off, which I'm not going to do because I don't know how to turn it back on, I just stood and talked to you, you might have begun to get a bit edgy. You might have begun to think, oh, I've got to take notes. Or I've got to think about it in a different way. And getting 300 students in a room and not producing PowerPoint is a genuinely frightening thing for a lecturer. Because they object, they protest, and then they start doing Facebook. So all the way through, implementation is about deliberately changing the world we live in, deliberately changing the things that we do. And I don't want to talk too much about this because it bores me, but there are different types of complex interventions. Actually, there's another important thing to say here, which is we talk about complex interventions. I just want to throw open to you guys. Can you think of a simple intervention? No. Nervous rustling of paper? No. I don't think there's any such thing as a simple intervention. Once you've got people involved and you've got more than one or two people involved, everything becomes complicated. It becomes emergent, which means that its outcome can't necessarily be predicted. And it becomes full of things called contingencies, which are things that are unique to a particular context. What NPT does is it tells you something about the core processes that run through implementation as action. It starts off by saying, if we implement a thing, some of us were talking about telemedicine systems or telecare systems for COPD earlier on. And let's just start by saying, a technology is not a thing. You know, this is not a thing. Obviously, it is a thing, but its thingness is surrounded by this great ensemble of cognitive and material practices. We have to think about its use in different ways. We have to be really careful. I mean, I can't obviously point it in this direction and press the button. There would be some issues, possibly a court case. So it has rules attached to it. It has norms and conventions and behaviours. Nothing is simple. But it's not overly complicated because, look, we've developed those rules and we know how to behave with a well, obviously we don't necessarily know how to make it work, but more or less we know how to behave. So we work to give the thing, we say it's an it, we always treat technologies or new systems of practices as though they're an it, as though they're a single thing, a single actor in a system. But there are lots of things. There's lots of investments that people are making in it. They're making it coherent. They're making it into a real thing. They're differentiating it from other things. They're giving it rules and meanings and values. And then they're participating in it. They're joining in. They're finding ways to join other things and other people together. And then they're actually making the thing happen. And has anybody here ever used a telemedicine system? Okay, so we've got one person. Was it easy?
It wasn't easy to start with because you had to embed into the current practice.
Yeah.
And patients took it quite well because it was easier for them. It was in cardiology setting.
Yeah.
And used around internal loop recorders. And in normal setting, they had to come to hospital to get their device offloaded, and they could do it just using an analog telephone line from home. Saving them trips and all sorts of things. So, and it was going back to some of the questions that whose workload it involves around. So it wasn't too bad in the end. Yeah.
So you were able to make it workable in your setting
because it was embedded in.
Patients were able to make it workable in theirs.
Yeah.
And you were both able to integrate it into your workflow.
Yeah.
Because patients have workflow too. Thank you very much. Patients have workflow too, and patients, in case you haven't noticed it, are the new workforce of the NHS. Actually, it's always been that way a bit, but those of you who've seen the Health Education England strategy for the next 15 years will see absolutely explicitly that the NHS aims to exploit patients and their carers as part of the workforce. So there's something new that's going to be normalised into those previously quite different relationships, which is the patient suffering managerial accountability as well as clinical surveillance and clinical interventions. So patients have key performance indicators. And you could think about some of those health checks as annual appraisals. So there are some things that are getting normalised from other places into the world in which we live and work. They're becoming embedded. The practices that are used to manage health professionals are also being shifted to the management of patients. And if you think that that doesn't matter, let me tell you about an experience I have in the United States. I sometimes work at the Mayo Clinic with Victor Montorio and his research group, and they were telling me that they had a big problem with the management of diabetes in primary care, which is that people who couldn't control their blood sugar were a problem for doctors, not just because they posed a clinical problem, but because if they couldn't control their blood sugars, the doctors were denied a payment. So actually patients were being fired for poor performance and lack of leadership. You know, quite an extraordinary thing. You know, people were being sacked by their doctors because they weren't delivering on their performance, on their key performance indicators. So we can think about how people interact with things, and it's important to think about how people interact with things. You know, how we interact and behave in an environment that's surveyed by video cameras is different to how we interact and behave in environments that isn't. I haven't, for example, said anything pointed about the Secretary of State for Health. Although I do have a slide sometimes which includes the words instrument of the devil. Now, I'm not making that connection too closely, since this is going to go on YouTube, and because it's not like, you know, when you see on Mock the Week and Mickey Flanagan says, oh, this will be edited out, and it never is. You know, never is edited out. So the things that I've been talking about are the interactional workability of things, how people can make them work in practice, the relational integration of things, how knowledge and information and trust are moved around and operationalised by people. Skill set workability, we talk about this all the time, whether people have the right skill mix, the right skill set, but actually skills and performances are what make things work. And then there is this brutal thing, contextual integration, which is actually about how things get realised and filtered and changed and made through the effects of others, about how we could talk about it in terms of resource allocation, but that would be a very crude way of doing it. And I'm just going to say, here's some work by Jane Spangaro in New South Wales, and she just used this to think about screening for intimate partner violence in pregnant women. And I like this because it's very simple. You don't need to have a PhD in the phenomenology of whatever to do this. These are actually sometimes simple questions with simple answers. So this got into practice because people could make it work, and because a lot of effort was devoted to thinking about these four things. You know, it was workable in the role definition of the community midwife. There was a script that people could follow. It was simple for them to use it. It possessed Darwinian simplicity, the survival of the easiest, and it could be done. We've talked again about coherence. I've talked about these different things several times. This is all about work that people do. It's about analysing and understanding the investments that people make when they do implementation. And I'm just going to show you some of the stuff from the Mayo, if I can make this work. So this very quickly was a shared decision instrument, a shared decision tool for people who just had an MI. It's worked by Rebecca Mullen and Victor Montori and Henry Ting and others at the Mayo Clinic. I was peripherally involved in this, and they used NPT to analyse the implementation of the thing. So, coherence, does it make sense to use a decision aid? Can it be made sense to people? When you describe it to patients, does it work? Yeah. Actually, cardiologists, no. Cardiologists didn't think it made sense to make a shared decision-making tool and use it because they saw risks attached to that. Do people understand it? Well, yeah, maybe they do. Let's have a look. Yeah, patients do. They could understand it. Bedside nurses could do it. Nurse practitioners could do it. Could they make it work? Could it happen for them in practice? Were there resources and skills? Were there... Yeah, there were. But not for bedside nurses. So we can see different constituencies emerging here who have different needs and do different things. You know, are the tasks feasible? By goodness, are they feasible or not? Yeah, they were feasible. And were they able to use the thing and make it happen and to make a decision? Oh, yeah, they were. I did wonder, though, what the intervention was. You know, we can see that there's a fantastic decision tool here. And in the NHS, we're getting very fond of option grids and decision tools and things like this. I did ask myself whether the intervention was the shared decision-making tool or the informed consent procedure in the trial. It's an interesting question. We talk about differentiating the different things, and it's so important to understand what the intervention actually is and does. So we were talking about COPD and telecare, that's clearly an interactional thing. It's an interactional device. It changes the way that people interact with each other. And that's important, and there's a thing there that's being implemented, which is a new way of talking to people, and it's governed by different rules and different behaviours, and it requires people to have technical competencies. But buried in there is something else that's being implemented, which is a threshold for care. So you've got to pass a certain level of blood oxygen saturation before you get to go to A&E. So embedded in there is a threshold for care and a technical standard. That's the other thing that's being embedded in there. And we embed and implement technical standards and thresholds for care all the time. We have to. So there is now a very substantial literature emerging around using NPT. We have a toolkit, and the toolkit is intended as a way of thinking through implementation problems. We have a website that people are using, and we built it for the NHS. We got a big grant to build it for the NHS, and when I came to write the impact report for the funder, I discovered that the one thing that we hadn't thought about when we designed this website and embedded Google Analytics in it was the NHS firewall. And that means that I could tell the ESRC who funded it that it had been used by the Baylor healthcare system in the US, Cook County Hospital in the US, Beth Israel. I mean, I could just write a list of American hospitals that had accessed this and used it in some way, and I could tell them how long they'd stayed on the site and other stuff. I couldn't tell them what they'd done with it because we wanted that to remain private. And also, we didn't have the mechanism to collect the data. So privacy ruled for a moment, and we didn't have to think about how we could know what people had done with it. But I couldn't tell anybody whether anybody at the RVI had used it. It was quite a sad moment for me, although it did enhance the international side of the impact statement. So this is kind of my swift guide to NPT. It's not a religious commitment, it's a theory. And a theory is an explanation. So it explains a number of important things that need to be taken account of when we're thinking about the conscious and deliberate process of implementation. It does not explain the world. It does what it does and no more. There are other theoretical models that we can use to trace the diffusion of innovations through organisations and adoption decisions. There are other models that we can use to think about how people rationalise the use of things and their attitudes and their intentions. And they're very, very effective. So NPT tells us what needs to be done in an empirically grounded way. So it's derived from observation and interview. It's not philosophical speculation. And I sort of think that's almost it. I was going to call this talk something like Adventures in the Sociology of Social Systems, or a phenomenological approach, or the joy of phenomenology, rather. But those were words that you don't usually find in the same sentence, joy, adventure, phenomenology, sociology. So I thought I'd call it an introduction to NPT. I hope that it's helped you to understand what we're about and what we're trying to do, and the tools that we're trying to give you.
Thank you all for sticking with us and coming back after the lunch break. We have a kind of just one key session left for the day, with a workshop at the end, and then we'll kind of have a discussion and sum up what we think we might be able to take away from this at the end. Definitely well in time for 3 o'clock. Okay, so in this session, we want to move on from trying out the tool and kind of working with the questions that represent NPT as a theory, to thinking about different ways of applying NPT to all the different kinds of problems that you're working with, whether that's within the NHS, within your work, or within research projects. Okay, so there are 2 different ways of thinking about this. One is to start by thinking, okay, what's the objective here? What are you trying to do? So are you trying to plan and develop an intervention? Are you trying to evaluate one that is already designed and planned? Or are you trying to develop your implementation strategy, for example? And I can't say we have lots of answers, and from the discussions I've been having throughout the day, we're maybe not quite there yet in terms of being able to give all the answers, kind of more towards the sort of implementation end part of the process. But we're definitely working towards that, and hopefully you'll see in this next session some of the different ways that we've been working with it, and that might give you some ideas of your own. So that's where we want to try and end up at the end of the day. The other part is if you are doing research and you want to use NPT, and when I say research, I don't necessarily mean formal academic research funded studies. I mean research in the broader sense. You could be implementing something in practice, but you still will want to collect some information about what's happening or what might happen when you introduce this new thing. So hopefully what you'll see is it's not purely about how you might use it in an academic way. Hopefully a practical way. Okay, and for this part of the presentation, I'm going to draw largely from a paper that we published in 2010. I have to look quite closely to remember. It doesn't seem that long ago, where we really tried to set out different ways of using NPT. So this was looking at how you might develop interventions, how you might use it to evaluate, and how you might use it to implement interventions. And there are some really good examples. And this is the paper that I usually send people to first if they come fresh to NPT and want to understand how it might be useful. So that could be a good starting point. Okay, this has already come up a couple of times, I think, today. When we talk about things that we're implementing, sometimes you really do have to start from the point of thinking, okay, well, what actually is the intervention here? Which bit of what I want to do is the intervention part? And more than likely, there will be a number of different interventions going on at the one time. When we're doing this in the context of research, as we often are, and often the way to try out something new is to get the research funding to enable us to do that, we're doing different things at the same time. So we have the service or the practice that we want to implement, and then we have the evaluation that kind of runs alongside it. And those things are often quite embedded together. And both of those things involve the kind of work that we've been talking about in terms of the theory. So the sense-making work, the participation work, the action work, and then the appraisal and monitoring. Okay, and what you're hoping is that the thing that you're interested in changing in practice should be able to continue afterwards. But the evaluation, you would hope, is time limited to an extent, which is not to say that you do it, you evaluate it, and you say, yes, it worked, and that's fine. But that's often more bounded. So you really want to think about the effectiveness of what you're trying to do in the longer term. And how widely it can be implemented. So if it's a research project, when that's finished, can you move it on to another place? Can you roll it out further? And that's what we're trying to understand a bit more with NPT. So we'll take a look for a moment at using NPT to develop an intervention. And today you've been using the tool to kind of think through interventions, and actually we've come up with some examples and made up some scenarios as if these are things that are already decided and already developed for you to think through. But you could actually use the tool and the questions within it to kind of really plan how the intervention should be developed and how it should be organized and delivered. So an example that we have in the BMC medicine paper, we've got an example of support for low back pain management in primary care using physiotherapists. So the first step is looking at the context. What is the context of practice to begin with? Okay, doing the kinds of things that we've been doing this morning around different perspectives. Who's affected by this? What might their perspective be? How might it affect their work? So actually, you've already been doing this kind of work with the examples we've provided this morning. You could use it to define what is the intervention, how does it change the tasks that people do. If you work through the questions, and before lunch you looked at the relational integration type questions about trust and confidence, try and think through how that, what it might mean for those sorts of issues, and can you design your intervention in a way that helps to address those and preempt some of the problems that might come from implementing what you're trying to implement. Okay, so really we would suggest using it as a tool to think through exactly what you've been doing today to develop that intervention. But an important point is that this should help you to think about, well, actually, is it feasible if we work through this? Are we identifying problems that we can actually address? Or are we not? Are we just identifying things that we can't change, that we can't fix? So it's using that as a planning, and it may be that there's a point where you need to decide, I've said evaluate or abandon, but it might be implement or abandon rather than evaluate it. And in this case, there was low coherence for GPs, but that was identified from the beginning. It didn't make too much sense to them, but that was addressed. And then they were able to engineer what they were doing to get better participation, because participation with all of these things is really key. Okay, and that's just a screenshot really from the paper. So you can see, you can kind of use the constructs as your kind of areas of work to think about what would be involved here. And there's some questions. So that paper could be really quite useful if you're interested in working through it in this way. Okay. So in this example, the GPs didn't see it as something different. Okay, so they couldn't really see what the point of it was going to be. Okay, so some of it the GPs saw it as research, and this is purely one perspective. We did look at different perspectives, and you could do this, you know, for the different groups that you're interested in, and compare those if you wanted to. Okay, so another way of using the theory might be to plan an evaluation study, or to optimize it and to give your research study the best possible chance of answering the questions that you want to about what you're trying to implement. And again, in the paper, we've got an example of a whole system approach to self-management for patients with chronic illness. So this is looking at a system of care within primary care and drawing on different people within the practice. So again, defining the context. And really the issue here, as with a lot of research studies, is participation and getting the practices and the stuff within those practices to engage with it, to complete the processes necessary, in this case, for a research study and a trial. And this involved training the whole practice team to provide self-care support for patients, to help patients to support themselves. Okay, so what they did was they undertook an exploratory study to try and optimize the trial parameters. So what that means is to kind of, you know, to optimize the processes so that the recruitment processes didn't get in the way of what they were trying to do, which was the self-care intervention. So again, doing what we were doing this morning, thinking about how this will impact on the people involved in it, but not only thinking about the care package and the new way of delivering care, but also thinking about the research procedures. And often what happens is lots of questionnaires, lots of outcome measure data that needs to be completed alongside the intervention. And if the tasks, if you combine all that together and the tasks are just too onerous, you then impact on participation and you get people, you know, not doing it, not signing it up to it properly. These examples are in the paper, so if you kind of want to see in more detail. But one thing that came out of this, a meeting that we had when we were developing this paper, was the idea that really you could use NPT as a trial killer, which is meant in the most positive way. And what that means is actually it might not be worth investing all of the money that it takes to run a randomized controlled trial over X number of years, which could be, you know, 5 years or so, because maybe it's just not feasible to do this in practice. That it has no real good chance of success as an implementation. And so again, another example of planning and implementation. This was across, was it Italy, all of how?
No, it was a couple of regions.
A couple of regions of Italy.
It was the bits of Italy that actually work. Yeah, the bits that had more money than the others.
Right, okay. Robotic surgery. And again, so this was thinking about the context, and this was something that was already being done in one region, but can we roll it out to somewhere else? And of course, what's important there is how is the context different? What's different about it? How might we need to change the intervention so that it fits in this new context? And we've already said about the difficulties in actually defining what the intervention is. So you could use this to maximize your approach to implementation and come up with ideas about how you might maximize that. Okay, so part of this whole process, whether you're designing, developing, evaluating or implementing, involves some kind of information gathering and some kind of data collection. So we want to say a little bit about different kinds of data that you might want, and how you might do that using the theory. And if, can I say how many people have already looked at the normalisation process website? Quite a few. And you may want to have a look after if you haven't already. But we actually have a manual about how to use the theory on there. We say manual in the loosest sense of the term. But we do have sections within that on how you might use it for data collection around reviews, surveys, qualitative research, and trials. But of course, it's guidance only. And really, we just offer up some things that you might consider. Okay, so we have used NPT in systematic reviews of the evidence around different kinds of things. And so you can kind of use it to frame your research question. Research questions most appropriate being around the implementation process of X, whatever X may be. You can use it actually as a framework for data analysis, and I'll briefly talk about an example of one in a moment. But you can use it, in a qualitative sense. You can actually use the concepts that we have within the theory to code the findings that are coming out within the papers that you're looking at in your review. So you can actually use it as a way of synthesizing the results of a number of different papers and presenting that in a way that helps you to kind of think about the questions that are important from an NPT perspective. It may be that you can use this. Often when we do reviews, some of them are quite quantitative and focus on outcome measures, and often that's what's of most interest is, does this new intervention lead to improvements in health outcomes? Often, if you've kind of read systematic reviews, what's the most typical conclusion of a systematic review is there's not enough. Sorry, more studies, not enough evidence, inconclusive. But so what we would like to say is that this can be a way, really, at looking at some of the more process-oriented information, and that's not always there in the papers. But if you've kind of queued up to look for it, and you have a way of thinking about it, that can help, and you may actually be able to interpret why those studies did or didn't show positive effects on outcomes. So that's a number of reasons why you might do a systematic review. I'm being wound on. Okay, so, and this was a really good example, if you're interested, around the implementation of e-health and processes around that used the theory. And this used NPT, and what we found at the time was a lot of emphasis on contextual integration issues. So this was about the context, resources, and other things like that, and much less information coming out of the literature around the interactions and how that affects people. Okay, qualitative research, most of the studies we referred to earlier, I would say most, have used this in a more loosely structured way with data collection from open-ended questions, either using the questions based on the theory or coming in at a later stage of a project where you've collected data and then you use it as a framework for analysing that data. Okay, so it can be used in a number of different areas of a study in a qualitative sense. And again, the point's been made, shouldn't be seen as a methodology or a method. It can be used flexibly. And this is a really good example if you're thinking about using NPT in qualitative research, because this paper particularly from Anne McFarlane in Ireland talks through the process of actually trying to translate these theoretical concepts into definitions particular to her study context, which was about the use of interpreters in primary care. Okay, and it allowed them to kind of really understand the context of what they were trying to do in terms of introducing and getting GPs to engage with using interpreter services. More recently, we've been doing work using NPT in surveys, and so some of you have had first-hand experience of that by completing the survey. Now, it has come to my attention that maybe some emails didn't quite make it through, perhaps, but still quite a lot of you did fill in that survey. And so I'll say a little bit about that. But why would you use surveys? Why would you use NPT as a survey? Okay, so it might be useful for different kinds of questions. If you're more in the planning stages, as you've seen this morning, using it as in a very open-ended way to think about the issues might be the best way to go. Now, if you're kind of much further along, perhaps, or you want to understand kind of how widespread some of these views are that you've been picking up in a more qualitative way, in a more open-ended way, then you might want to use surveys to think about this in terms of kind of how much of a problem is coherence, for example? How much of a problem is participation? You might want to compare different places. If you're implementing something in different settings, you might want to structure your data collection in a way that allows you to make those comparisons a bit more easily. So that might be a reason to use NPT. In terms of developing measures, often what we want to do is develop tools so that we can do lots of complicated statistical analysis and see if we can find ways of predicting what will happen. We've always been clear about NPT is that we can't make predictions. But what we can do is look at what the potential is for something to become embedded. And that's what we're exploring right now in the study. So the survey that some of you have done is our kind of most focused attempt at trying to explore whether that's useful or not. And part of the idea of this is that not everybody has the time or feel confident enough to go around asking lots of very open-ended questions about these things and pulling all that together and making sense of it. Some of you may be more familiar with tools that are structured, and that might be an easier way to use the theory, although it's not always going to be the best way, as hopefully we'll be getting across today. We did do this work initially in e-health, and we developed an NPT-based instrument on e-health and the implementation of that. So the questions are very much framed around that, although what we find is the issues are quite generic in the way that we've been talking about them today. So what the survey that we sent out is part of the NOMAD study, which is funded by the ESRC. So that's the work we're doing at the moment with quantitative work. And so there's just a couple of papers about that if anybody's interested in exploring it. And we are looking for examples where people might want to use our surveys, and we'd be more than happy to work with you if that's the case. Get in touch, but this study is closing fairly soon, so if you've got something that this might be useful for, get in touch and we'll talk about whether we can do that. Okay, but some warnings as always. It might be useful for giving breadth of information. If you're implementing something in a number of different places. But you need to have enough people who are involved in actually delivering these interventions to make it work in a survey kind of way. Most of you will appreciate if you only have small numbers, then really structuring your data collection around numbers is not useful and can be quite misleading. What you need is enough people so that you can be sure that you're getting a good, you're capturing enough different perspectives within that. Okay, so recognize the limits of that as well, the survey data. Often it's used more for measurement, but it might not be as useful for planning. That might be where you need to have the more open-ended discussions. And even though we do have tools, we're developing more tools, it's important to say you still need to customize and localize these. And the survey that we sent out, when we go to different sites, we have to amend parts of it so that so it fits the context. Even if the actual questions within it are the same, we have to really understand what the context is and what data collection we need about that context for the rest of it to make sense. Again, we've already talked about trials a little, and so it could be that something new has been proven to be effective, but actually it could be just quite problematic to implement, and that might be for all sorts of reasons, to do with the context or to do with the staff involved and whether they can be trained and all sorts of issues. So you would really want to think carefully about who do you expect to use the results of the trial, and what can you do to make sure that it's relevant to them, that the results can be taken up and used somewhere else. And there's been some good work done in Melbourne with people that I think, Carl, you've worked with, who've looked at NPT in trials around midwifery services. So just a few things, again, to bear in mind about using NPT. It's not about an individual's own intentions and perceptions about what's going on. They're important, but they're only really one very small part of the story here. So it's focused on helping you to understand how this work is a collective activity, how it involves people doing things together and working together to make it happen. So what we would hope is that this will help you think about the range of people that are important, the range of situations that you need to consider, when this is being done in practice, the different times, the different places. This is all important if you want to really optimize, what you're implementing and the approach that you take. Okay, so context is all important. And NPT needs to be adapted with whatever context you're looking at. And Carl's famous quote that we keep coming back to is, it's not a theory of everything. And actually, we're really depending on people to use it, to try it out, to feedback, to tell us what was useful about it, what was limited about it. And it's only by doing that that we can keep building our knowledge about how it's useful, so that we can keep working on it. This will continue to develop and grow, really, for how long? Forever.
We would have stayed. We loved it. We would have stayed.